So we kind of left off right here on the cerebellum. We're kind of going through this big overview, and right now we're focusing on just looking at the regional anatomy, surface anatomy of, we started with cerebrum, brainstem, now in the cerebellum, and then we'll move in the spinal cord and some blood supply and meninges, and then we'll be about done with that. So cerebellum, we stopped yesterday here. It plays a role in coordination. Okay, lots of information comes from your peripheral sensors, your muscle spindles, joint receptors that go up to your cerebellum. That information gets processed unconsciously, and then that information influences motor signals as they come down to adjust movement, to correct error, and those kind of things. So that's the purpose of the cerebellum. The cerebellum, here I'm going to change this to yellow. So cerebellum is this whole structure here, and then this portion here is the anterior lobe, and then this real big portion back here would be the posterior lobe when you're looking at it in a sagittal section, mid-sagittal section here. This is the fourth ventricle right here, that space, and this is where cerebrospinal fluid is coming down, and you'll see that in a second here. But when we pull the cerebellum off and cut it off, and we're looking down here into this area right here, this is where that rhomboid fossa is. Remember we talked about that rhomboid fossa? That's the floor, the fourth ventricle we call it. So that's what you're looking at when you pull the cerebellum off. The picture down here on your lower left is the front of the cerebellum as it's been cut off of the pons. Okay, and so what you're seeing here is the cerebellar peduncles, which is what connect the connecting stalks to the brainstem, and you'll see it has that. Let me change this to a little bit darker color. You'll see it has, this is the middle cerebellar peduncle. This is considered the inferior because it just sticks out a little bit lower, and this is the superior cerebellar peduncle. Superior, inferior, and middle. The middle is always the bigger structure there, and then you've got a superior and inferior cerebellar peduncle. You can also divide the cerebellum into, we call these vertical divisions. Okay, so the vertical divisions are the vermis. Vermis means kind of worm-like, and if you imagine it, it kind of maybe looks a little worm-like through here. But this is the vermis. This is the picture here. This is looking down at the top of the cerebellum. You know, the cerebrum would be over top of this, but this area right in here, this middle area, then that goes all the way down, wraps all the way around the cerebellum, is the vermis. That very medial aspect of it is called the vermis. And then when you come out just a little bit farther, this area here is the paravermis. So these areas here, the paravermis or paravermal regions. And then these areas most laterally are the lateral hemispheres. Okay? So, and then in this view, here's the paravermal regions, and then these areas out here are the lateral cerebellar hemispheres. And we'll do a whole lecture on cerebellum and basal ganglia and all that, and you'll learn about how the role that those play, and why it's important really more to know those vertical divisions than it is the anterior and posterior lobe. Okay, the vertical divisions are more functionally relevant, and what parts of our body are controlled by the cerebellum for coordination. Okay, now we're moving out of the brain, which included the cerebrum, brainstem, and cerebellum. Now we're down in the spinal cord. So real quick, it lies in the vertebral column. It goes from that foramen magnum, all the way down to essentially that inner space between L1 and L2, the disc between L1 and L2. So that's a significant thing to know, is that the spinal cord does not go all the way down the spinal column. It stops at L1, L2. So when we talk about spinal cord injury and where you have an injury, whether it's lower than that L1, L2 versus above that L1, L2, that makes a difference on the type of symptoms you'll have regarding your, you're really not even injuring the spinal cord per se. When you have an injury below L1 and L2, you're injuring what's called the cauda equina, which is all the lower motor neurons and sensory neurons that come off the bottom of the spinal cord. So the cauda equina is that, we call it, it's horse's tail is what it means, but it kind of looks like a tail. It's all the nerves that are kind of compacted into that very end of the spinal cord, because it ends at L1, L2, but all your lower lumbar and sacral nerve roots still come off that end. That's what's coming off. They got to still go down and then come out their respective areas at their appropriate levels. Okay, but those nerves go down and come out. Okay, there's a little tiny piece of This is actually pia mater, which we'll talk about in a second. There's a little extension of pia mater off the tip of your spinal cord called the filum terminale, and it actually goes down and anchors your spinal cord to your sacrum. And it's just this little tiny, almost microscopic, although you can see it. It's a little tether that goes down to the sacrum. You have 31 pairs of spinal nerves. There's the breakdown. Just showing you here. So here's the picture on your left. There is a sagittal, mid-sagittal section through the spinal column and the spinal cord. And you can see here, there's where the tip of the spinal cord is. It actually ends at that L1, L2 disc space between the L1 and L2 region. For most people, it can vary by, a few millimeters or millimeters in that area. But for most people, it ends at that L1, L2 disc space. And then, all the nerve roots that come off the end that still have to go and exit at the lower lumbar and sacral levels, that is what makes up your cauda equina, okay? There's a little tiny piece of pia mater called the filum terminale that extends down from the tip to the sacrum, sits down here, okay? One thing to be aware of, if you'll look at the, couple things to be aware of. Looking at the sagittal section, in the sagittal view, where you see the nerve roots in the cervical spine exit, they exit above their vertebral level, okay? But then you have a C8 nerve root, and you don't have a C8 vertebrae. So then what that causes to happen is then once you get below that, start getting into the thoracic level, they exit below the level of the vertebrae. So that just becomes significant when you hear somebody, you're reading somebody's chart and they have a disc bulge at a certain level. You should be able to determine or have an understanding of what nerve root most likely be impaired if it's in the cervical versus the thoracic and lumbar levels. They'll be a little different. Or if somebody has a spinal cord injury or has an injury to, they have a vertebral body compression fracture at a certain level, what nerve root is more likely to be impacted. And we'll get into that. We're going to do a whole session on spinal cord injuries, and get into the nitty-gritty of how that impacts that. In this frontal view here, the coronal view, looking at the front of the spinal cord, there's an area right here called the cervical enlargement, and then there's also an area down here called the lumbar enlargement. That's just where cervical part of your spinal cord is bigger. Why do you think it's bigger? Why do you think why is the spinal cord in your cervical area bigger? What is it subserving, or what is it doing? What about all these little muscles in my hand, all the sensory receptors in my hand, a lot of muscles in my forearms? There's a lot of motor neurons in the cervical spine because you have a lot of small muscles that you have to drive and coordinate and move. So actually the cervical spinal cord is a little bit larger, so there's a little less space in that cervical area, and that's why it's very common to have bulges and disc bulges in the cervical spine in certain areas that can impact the actual spinal cord itself. And then down, same thing, lower lumbar here at this cauda equina area, and this is called the conus medullaris, this tip right here, the very tip of the conus medullaris. That's where a lot of those spinal nerve roots to go all to the lower lumbar and sacral segments are coming off, so there's more stuff going on in there. There's more nerves, and so it's a little bit bigger because there's more white matter, more gray matter in there, so it's a little bit enlarged. This is looking at, it's a hard picture to kind of wrap your head around here, but this is looking at the back of a cadaver here that's had a laminectomy all the way down. They've taken the lamina off the spinal column, so you're seeing the spinal cord laying in the spinal canal, and this is the conus medullaris right here, tip of the spinal cord, and then this is the cauda equina, all this stuff here. Sacrum is down here, and there's a little tiny piece of a little bit lighter colored. You see this? This is the filum terminale, that little tiny structure there that anchors down to the spinal cord. And there's a thing that sometimes, depending on if your spine grows faster than your spinal cord, you can have this tethered cord syndrome and so forth. You may hear about that more in pediatrics and so forth. But and some people assume that that is related. You'll hear theoretical things about, what is it, craniosacral therapy, where you somehow you're supposed to be able to feel the cerebral spinal fluid moving, and it moves your sacrum, and would be one of the mechanisms because of this connection with the filum terminale and all this stuff. So I don't believe it, but that's one of their rationales. Cross section. So we're looking at a horizontal section through the spinal cord here. The gray matter is in the middle. So the gray matter is this H structure in the middle that it has. Okay. Whereas in the cerebrum, it's on the outside. The gray matter's on the outside is the cortex. But you do have the basal ganglia. There's a few deep gray matter types of structures in the cerebrum, like the thalamus and the basal ganglia. But in the spinal cord, all the gray matter's in the middle, and the white matter, the axons that are carrying information up and down the spinal cord, are all on the outside. Okay? You've got a dorsal horn. This is the back part. These are the dorsal horns back here, and then you have ventral horns. And in your thoracolumbar region, you also have a little bit of a lateral horn, and we'll talk about those later. That's actually where some of the cell bodies for your sympathetic nervous system are. Okay, so the back part of your spinal cord is associated with sensory function. The front part is motor. Okay, then the white matter. These are these regions here. These regions here, the white matter. And it's divided into a lateral funiculus on each side, a posterior funiculus, and an anterior funiculus. Remember, funiculus is a larger, then you have these tracts that run up and down in there. So when we get to the tracts, we have back here, this divides into the two dorsal columns back here on each side. But it's also called the posterior funiculus. It's just, you hear those terms, that they mean the same thing. Dorsal columns, posterior funiculus. Just showing you a cross-section, a horizontal section of a spinal cord segment with the bony structures around it. So this is where you see the vertebral body out front here, the big vertebral body out front, the vertebral lamina, okay, back here. And you can just see it laying in there, and you can see there's the dorsal horn, anterior horn. There's an anterior root. This is where your motor nerves go out, and also your autonomic nerves. And then there's a dorsal root back here and a dorsal root ganglion. This is where your sensory nerves, there's a cell body in here, your sensory nerves come in the back part of your spinal cord. That's what you're seeing there. And the coverings, you can see some of the coverings here. So those, we'll get to in a second here, you'll see the coverings. The meninges, collectively they're called. There's three. There's the pia, arachnoid, and dura. And so in here, the dark purple right here that's right on top of the spinal cord is the pia. And the extension of that pia at the tip makes that filum terminale. But when it's on your brain and on the spinal cord, it's on your cerebellum, it's on your brainstem, it's microscopic. You can't see the pia because it's just a couple cells thick, okay? So that's the pia. And then the next layer is the arachnoid, which is this layer here. And then finally you have the dura. The space between the pia and the arachnoid is where all your spinal fluid is running, okay? So you have spinal fluid in there between the pia and the arachnoid. So there's a reason when they give you like a spinal anesthetic that they always do it in this, below L1, L2, because the needle, when they stick it in here and squirt the anesthetic into that region, at least they're not going to hit the spinal cord. Usually the nerves move out of the way, the cauda equina, but occasionally they nick a nerve when they put that needle in there. Then you have to wait a little while. It damages some of the myelin, and some people have some pain. It's like a burning sensation. It might take a few weeks, a few months to repair. But when you have a spinal anesthetic, then that's how they do that. There's a lot of space in there for that. So as I mentioned, there's coverings of the nervous system. These are just protective layers of the nervous system. It has three different layers. The dura mater is the most outer layer. So dura is tough, mater is mother, tough mother, literally. So that's what it means, tough mother. It forms a couple structures. The dura mater, when it goes down in between areas of your right down the middle of your brain there in that longitudinal fissure. When it dives down in there, it's called the falx cerebri. When it goes up in between your cerebellum and the bottom of your brain, the dura mater goes up in there, it forms a tent, the tentorium cerebelli. It's the tent over the cerebellum, okay, the tentorium cerebelli. It also forms the dural sinuses. Your dura actually makes these tubes, and your venous system of your cerebrum drains into those tubes. So you have veins within your cerebrum, but eventually those veins drain into these, they're not veins, they're dural sinuses. They're like drainage ditches, basically, big drainage ditches that are made out of dura, okay? And those eventually end up in your jugular vein and then go back into your system. The arachnoid mater is the next deeper level. Arachnoid, spider-like, spider mother, arachnoid mater. It does look kind of like web, like a spider web. When you look at some of these specimens today, a fair number of them still have some, especially on the medial surface, still have some of the arachnoid on it. There's no dura on these, and you won't see the pia. It's microscopic, so you'll see some arachnoid that just hasn't been picked off. It's kind of milky, you know, looks kind of like a spider web, okay? That's where the subarachnoid space, the space between the pia and the arachnoid, is where the cerebral spinal fluid is. Because we pulled these brains out and pulled a lot of that arachnoid off, the cerebral spinal fluid leaked out of there. If you pulled it out without damaging it, it would feel kind of poofy and a little liquidy, gelatinous, because there's still cerebral spinal fluid in that subarachnoid space. It's a potential space. As long as there's something in there, there's a space. If you put fluid in there, it'll take up that space. But if there's no fluid in there, it just goes flat down on the pia. So it's a potential space. As long as there's something in there, there's some space there. And then pia mater is the next deepest layer. So that's the delicate, pia is delicate mother. So it's that single microscopic layer on top of directly on top of the nerve cells and the structures. And if you think about this from inside out, it's nice because it spells P-A-D, pad. But just remember that's from the inside out. That's pads your brain. It's protective covering and helps protect. It has some nourishment properties. Well, it doesn't have, the meninges don't. The cerebral spinal fluid does, but they provide a protective membrane. This is kind of a little cross section of the cerebrum with a part of the skull here. You can see here's the dura, the tough mother. Here's the arachnoid, and it has these little end feet that come down. But then it has this space here where the cerebral spinal fluid is running in between that space. Cerebral spinal fluid is made inside of your brain and inside of your cerebellum and brainstem area, and then eventually it gets out and then goes around the outside of your nervous system, central nervous system, and circulates around the outside of it. It starts on the inside, and then there's a couple holes where it gets out. And then here's the pia right here. And then you have your gray matter here, and then your white matter below. And the blood vessels, most of your blood vessels on the surface of your nervous system are running in that subarachnoid space. So if you hear the term subarachnoid bleed, that means there's a bleeding going on, typically an arterial bleed of a vessel in that subarachnoid space. That's bad. That's usually bad. That's a high pressure bleed. Subarachnoid bleeds are not good typically. Okay. This is this is the back of the brain, and we've taken away some of the skull here, and what they've left, they've taken off. Normally, this would all be covered with dura. The whole outside of this brain would be covered with this tough, sinewy, you know, it's kind of glistening white, but it's really strong, leathery. I don't know if you guys have seen any of the dura yet, but it's real tough. But it's been removed. But what you can see is remnants of where this is where that. Yeah, let me get to a little lighter color. Right here, you can see these little dural areas. This is what goes down in between, down the middle of your brain, that dives all the way down to your corpus callosum. That's the falx cerebri. And then it also dives in here between the inferior surface of your cerebrum and the superior surface of your cerebellum, and it forms kind of a little bit of a tent like this, the tentorium cerebelli. And when we take a brain out, when you the hardest part about taking a brain out is you got to like go almost blind with a scalpel, and you have to cut the tentorium cerebelli in a very specific way, because if you don't, you pull the cerebrum out, the whole cerebellum and brainstem stays stuck in the brain, down in there, and the tentorium cerebelli, the dura, holds it in place. So you got to actually do a kind of a weird blind cut to get the tentorium to get out of the way. So it's fun just to go in and see that so you can appreciate three-dimensionally how that works. This is a sagittal section through the brain where they've left the falx cerebri. So this is the dura right here that they left in between. Here's the tentorium cerebelli, the dura coming up in between the brain and the cerebellum here. Okay, so that's what they're trying to show you there. You can see the dura extends all the way around here, down the spinal cord, and you can see this, you know, so all this space here where the cerebral spinal fluid is flowing. Blood supply. So any questions on spinal cord, meninges? All right, real quick, blood supply. Don't get too hung up on this. Our brain needs blood, needs it all the time. It's via two major types of blood supply, regional supplies. One is the internal carotids, okay, so the internal carotids. They provide blood to most of the cerebrum, especially the front and top of your cerebrum, is mostly through the internal carotids. And they're kind of coming straight up and going right up to your cerebrum and supplying most of this front lateral part of your cerebrum, okay? Then you have the vertebral arteries, which are coming up through your neck, right? So your internal carotids, but your vertebral arteries, they come up and they join to form the basilar artery, and they split into the posterior cerebral arteries, but they supply the brainstem, the cerebellum, and the lower back part of your brain, the occipital lobe and the lower parts of the temporal lobes. So the vertebral arteries supply most of that, okay? I mentioned dural sinuses. So in order, then once the blood's up in your brain to get it back out, when it drains through these dural sinuses, okay? Here is the internal carotids right here. I'm circling the two internal carotids, okay? So you got, they kind of are coming up from your face and neck that goes up through there. Your external carotids go to supply the blood supply to your face. The internal carotids go up to the brain, okay? So that's the internal carotids. They divide into a couple arteries here. They divide mainly into your middle cerebral artery, which you can't see it, and your anterior cerebral artery, but then those go to supply that big part of the outer and front part of your brain. But then here's your vertebral arteries, all right? They're coming up through the cervical spine to those vertebral foramina. And remember, those are the ones that when you go, if you go to a chiropractor or we're doing a manipulation and we want to test vertebral artery testing. Have you guys learned any of that yet? You know, there's a concern you could pinch one of those or tear one of those and get a dissection. They call it dissection of the vertebral artery and stroke somebody out. That's because these vertebral arteries are running up through those parts of your spinal column, through those vertebral foramina, those little holes in your foramina there on your spinal column, and they're vulnerable. But they come up to join and to form this basilar artery. But you can see the branches that are coming off the vertebral arteries here. These are going to supply the cerebellum down in the lower part of the cerebellum. Here's another branch that goes off to supply the upper part of the cerebellum. And then we have more branches here that also go to supply the upper cerebellum and some of the cranial nerves. But then they divide into this posterior cerebral artery here. Don't need to know this detail yet, but those dive back to the back part of the cerebrum to supply the occipital lobe and the inferior temporal lobes. And then here's what it looks like in real life. And so this is the cut end right here. That's the internal carotid there, and there's a cut end of an internal carotid here. So it doesn't look as nice and pretty in the real life. And they've actually stained this one so you can see those arteries better. Normally you can't, they're not red like that. There's a cut end of a vertebral artery here and a cut end of a vertebral artery there. And then they join to form, this is your basilar artery here. And you're dividing in, this is your posterior cerebral up here. That's all we're going to say about blood supply right now, just to know that for the moment. The ventricular system, okay, so the ventricles. So inside of your brain, you have these spaces. So when you look at these brains, what you're going to see, actually you should be able to see, not on all of them, but most of them, one of the lateral ventricles. You'll be able to stick your finger or your probe right into the lateral ventricle, okay? So you have two lateral ventricles, one on each side, okay? That's your ventricles 1 and 2. But you have two lateral ventricles, right? And they're C-shaped. See how they wrap around and they're C-shaped? They have an anterior horn, an inferior horn, and a posterior horn. If you kind of stuck your finger or your probe in there, you could get into some of those areas, but don't worry about that. Both of the lateral, so in the lateral ventricles, there's a substance called choroid plexus, and a lot of it's right in here, and most of it's been ripped out from your brains. There's probably some somewhere in there. Choroid plexus is like a capillary system. It filters blood and makes your cerebrospinal fluid. So the cerebrospinal fluid is made in the lateral ventricles. There's also some in the fourth ventricle. And there's maybe a little bit in the roof of the third ventricle here. So cerebrospinal fluid is made. It goes through a hole right here that connects the lateral ventricles on both sides with the third ventricle. And the third ventricle is just this one area right in here. That's the little slip of space between the two thalami, the thalamus and the hypothalamus. So the space between the diencephalons on both sides of so when you cut right down the middle, there's a little tiny space, and that's the third ventricle. It's potential space. When you're looking at it, there's no third ventricle when you've cut it apart. You're looking at one side of it, or the side of the ventricle, but there's no third ventricle unless you have another side to it to make your third ventricle. But it's just this little sliver of a space there that fluid runs down between the two thalami and the diencephalons there. And then it goes into a little duct called the cerebral aqueduct, and that cerebral aqueduct takes it down into the brainstem. And then it goes into the brainstem, and it goes into the fourth ventricle. So our two lateral ventricles are 1 and 2, then the third ventricle, then it goes down to the fourth ventricle. And then when it gets to the fourth ventricle, that cerebrospinal fluid, there's actually 3 openings. There's one right in the center, right underneath our cerebellum, and there's 2 on just the sides of our cerebellum that the cerebrospinal fluid then gets out into that subarachnoid space and then can flow around the whole nervous system. Okay? We'll talk later how that's recycled so it doesn't build up, but there's a way for that to happen. Okay? That was just a real quick introduction to the ventricular system. All right. So now clinical application of neuroscience. So just to kind of give you a few things about neuroscience. Turn this down. Come on. And some cues that when you look in your book that'll help you from the clinical side of things, because this is very clinically focused, is we want you from this class to be able to understand, how different lesions affect the nervous system and how that will influence your treatment as a physical therapist, not as a physician, not as a pharmacist, but more as a physical therapist. So we're going to try to, you're going to be able to know enough about the nervous system that if you don't have it in the chart, you'll be able to do an exam and maybe rationalize and locate where a lesion would be, or vice versa. If you get at a chart and you got an MRI report and you know where the lesion is, that you can probably at least sort of figure out what you're expecting to see from that patient before you walk in. And if things don't match up, then you're saying, hey, should I refer this patient out? Has this person got a problem that I as a physical therapist shouldn't be treating, and I need to refer them out? Okay, so that's understanding some basic differential diagnosis so you know when to refer. Okay. When we talk about lesions of the nervous system, they can fit under 3 major categories of lesions. So we're talking really broad right now. One is a focal type of lesion, okay? So that's where you've got a circumscribed area that's been damaged. A small stroke, or it could even be a large stroke, it's still focal. There's parameters, there's boundaries to the lesion, or a tumor as affecting one part of the brain, brainstem, spinal cord. That's a focal lesion. It's individual in nature, it's focal. Then we have multifocal type lesions, so that we can have a tumor now that's metastasized, so you have multiple lesions. And that gets more tricky because then that can have symptoms that are very wide-ranging, okay? Or something like multiple sclerosis, which you can have scarring and lesions of the myelin in the central nervous system. It could be in the cerebrum, it could be the brainstem, it could be the spinal cord, but they can be all over the place. So that's very frustrating for the patient. It's frustrating for you because it's hard to kind of nail it down. They're like, wait, this doesn't make sense. Sounds like you're faking it almost because you've got symptoms everywhere. And for a lot of years, people with MS, they didn't believe them, until they had the ability to do MRIs to find out it's not all in their head. Well, it is in their head, but it's also in their spinal cord. It's also in their brainstem. And so that's why they have all these different symptoms. And then there's also what we call diffuse type lesions. So those are things that affect big regions of the nervous system, you know, like Alzheimer's disease affects a significant part of your frontal lobes and your temporal lobes and your cerebrum, okay? Or cerebellar atrophy affects a big region of the cerebellums. Or meningitis or viral encephalopathy, things that cause broad inflammation over the whole, your whole cerebrum or spinal cord and those kind of things. Those are what we call diffuse lesions. Then we have specific etiologies that lead to these lesions, and these are the classifications. You can pretty much classify any specific individual pathology under this type of an etiology. So one is trauma, so some type of trauma that actually is disrupting, tearing, dying off of cells of neurons or nerves or peripheral nerves being traumatized. Vascular disorders, so any type of either not enough blood getting somewhere, so we call that an infarction, so they don't get enough blood going to somewhere, or too much blood in an area that causes swelling and pressure, and also that is not actually getting into the cells, but just bleeding around the cells. You actually aren't getting the oxygen and the nutrients to the cell, it's just bleeding around it. So those are vascular disorders. So stroke would be your main one there. Inflammation, any kind of inflammation. Degenerative, lots of different degenerative diseases out there. Parkinson's disease, MS is considered a degenerative disease. So Alzheimer's, those kind of things, those would be degenerative disease. So like Alzheimer's would be a degenerative diffuse disorder, right? Neoplasms, any type of tumor of the nervous system. Immunologic, okay, so you have something like a viral encephalopathy or bacterial meningitis. It's an immune disorder. Your immune system's reacting to something, and then your nervous system's getting hit in the process. Toxic or metabolic is the other major category. So things like copper and manganese poisoning, carbon monoxide poisoning, those kind of things, drug overdose, that kind of stuff can cause toxic and metabolic symptoms to the nervous system. So that's pretty much what things can be classified as. When you're doing a neurologic evaluation on a patient, you're kind of concerned about a couple major things. When you're taking that history, speed of onset is critical. That's going to tell you a lot about, potentially what this disorder. If it comes on rapidly in an instant, I'm thinking vascular, a blood vessel just blew on this person or just got blocked up. That's typically, that's a vascular event, or it's a traumatic event, something they just got in a car accident. If it came on acutely and instantly, then that's probably going to be a traumatic or vascular event. If it's something more subacute, like it's taken over a course of a few days to a few weeks and the symptoms have progressively gotten worse, that could be a lot of different things. That could be inflammatory, it could be degenerative. It's not so clear what that is. And then chronic, months and years. If this person is experiencing months and years of symptoms, then it's probably, and they're not stable. If they're getting worse or something like that, then it's probably more degenerative in nature. So just knowing exactly, the history of onset, how fast what's the pattern of progression? Is it slow, fast? Does it relapse, remitting? It gets better than worse and better than worse. Does it affect mental status? If somebody has something that affects mental status, it's affecting the cerebrum, okay? If it doesn't affect mental status, if it's pure motor and sensory, it may not be involved in the cerebrum. It could be brainstem, spinal cord. But if you've got language or mental status dysfunction, the cerebrum's probably involved. If you've got some type of a language deficit or a mental or personality deficit, there's something going on in the cerebrum. Then you're going to do your specific motor, sensory, and mental function tests as a physical therapist. And then hopefully you can come up with a diagnosis. We're not diagnosing necessarily the physician's doing the diagnosis of the neurologic problem. We're diagnosing the physical therapy diagnosis of why this person's stroke is leading to movement impairment. And so knowing where that location, that lesion, will help you understand why them having the movement impairments they are, so that you can prescribe your interventions to best reduce those. When we talk about lesions, your Crossman book, the thinner book, the bigger, thinner book, the Crossman book is the one. They've got a couple of neat diagrams in there, and I just wanted to point them out to you, so as you're going through, you don't just kind of neglect them or don't understand what they're there for. So you'll see when you go through different chapters and they're talking about different regions, they'll have these clinical boxes of like clinical relevance of what's going on with like a spinal cord injury or brain injury or stroke or something like that. And they'll use these schematics to show what's going on. And so the one here, looking at the left, this is a schematic of the entire nervous system. And so they use this schematic then to show impairments or lesions. And so the one on the left is just showing you, it's the key for you. So you've got cerebrum up here is what they're trying to show there. You've got the basal ganglia right here. That's all they're trying to show that. And you'll see it's labeled basal ganglia. There's the ventricles here. That's just signifying any of the ventricles. These are signifying your cerebellum. Here's your midbrain. Actually, I take that back. Your midbrain's here. This is pons. This is medulla. And then this is spinal cord. Okay? And then this is a cranial nerve. This indicates any cranial nerve. Okay? Representative of just a cranial nerve coming off of somewhere in the brainstem out to its effector site. And then here's motor and sensory here. The blue is sensory. The red is motor. Okay? And so then they might have something in the little box where they say neurodegenerative disorders. So this is a box showing neurodegenerative disorders. And so what you do is if you look at this, it shows you things like Alzheimer's disease up at the top here. And it has a thing pointing to it basically affects the cerebral hemispheres. Okay, that's what they're trying to show you is it's a neurodegenerative disease that affects the cerebral hemispheres. Huntington's disease, that's a disease that affects the basal ganglia. And it actually affects a specific part of the basal ganglia called the putamen, which they don't break it down to that level, but it affects this part of the basal ganglia right out here. So that's Huntington's disease. Parkinson's disease, it also affects the basal ganglia, but a different part of it, but it's actually right here in the midbrain called the substantia nigra. Okay, so that's what they're showing with that. And then just, here's cerebellar ataxia, degeneration of the cerebellum, motor neuron disease. Okay, that would be like ALS, amyotrophic lateral sclerosis, can cause weakness of motor neurons coming from the spinal cord. So that's all that. It's nice though, but you get to see them all in one quick shot. Those are a lot of the major degenerative diseases of the nervous system and the different locations they affect in the nervous system. So then you'll also often see this little schematic here. So this is the kind of key to the schematic. So this is showing you, so if you're looking at a clinical Pearl thing or a little box there, they'll show you, this is how a normal person presents. And what they'll show is here's going from your left to right. The first body or diagram is supposed to show what's going on with the cranial nerves and motor system for that individual. Right now, this is a normal person, is showing no lesions right now, no impairment of the motor system or cranial nerves. This is reflexes. You'll see that this person has one positive reflex for each of the major reflexes: knee, ankle, cremasteric, wrist, elbow, or brachioradialis, biceps, and triceps. Okay, so showing a one plus sign means that's a normal response of normal reflexes. Probably best to put 2+, but that's okay. And then sensation, again, a blank body indicates no problems with sensation. This one indicates coordination. A nice straight arrow for the arms and the legs indicates smooth, coordinated movement, that the person can move smoothly with coordination. And so then you have a key here that if you see a part of the body outlined in a green color here, that's going to indicate muscle weakness and wasting. Actually, if the entire limb is like colored in that area. If it's just outlined with it, that indicates muscular fatigue. If it's outlined in red, the outside of the body is outlined in red, that's indicating what's called spastic weakness, which is indicative of upper motor neuron disorder, which we'll get to later. If you see a picture of a bladder right here, they'll show a bladder kind of right there. That means they are incontinent. If you see a negative sign for reflexes, that means they've got no reflexes. If you see extra positives, it means the reflexes are heightened. If you see an arrow down, did we talk about Babinski reflex yet? We didn't talk about Babinski reflex. Normally when you scrape the bottom of somebody's foot with your thumb or your reflex hammer, your big toe goes down and kind of, so that's normal, is a down-going reflex. But if you scrape the bottom of somebody's foot and their big toe goes up, that's not a normal reflex. That's using indication of maybe an upper motor neuron problem. So that's what this up and down Arrows are here. And then if you see this kind of wavy line, arrows, if these turn into wavy lines, that means the person has poor coordination. So this is what the key looks like for somebody who's had a stroke. So on the left is this schematic of the entire nervous system. And they're showing you, here's this person with a lesion. And that's on the lesion is in the white matter on the left side of the brain, right? Okay, so that's what they're showing you there. This is a coronal view through the cerebrum, basal ganglia, brainstem, spinal cord, okay? And so then now you use this key to help you. What are the deficits that this person's going to have in motor system and cranial nerves, reflexes, sensation, and coordination with that lesion, okay? And this is what this person could potentially have. Since it's outlined in red, that indicates both the arm and leg, the entire right side of the body is spastic and weak. Okay, so it's upper motor neuron spastic weakness. And oftentimes people with a stroke, their upper body will go into what's called a flexion synergy pattern. Their tone goes up in that arm, so that's why it's showing you like that. And also their leg on that side goes into extension. So that's why you see that foot pointing down more. So it's kind of nice. It's just a really good illustration of what a person looks like when they've got a lesion on this side of their brain in that white matter that could cause hemiparesis, spastic weakness on the right side of the body, arm and leg involved. Doesn't cause any problems with cranial nerves typically. It can. They can have weakness in the face and the tongue, but it's not showing that. It doesn't show that right now, but I'm surprised it doesn't, but it can have weakness. They could outline this in some red here if they wanted to. It also mentions the person might have aphasia, which is difficulty with language, okay? Especially if this lesion's on the left side of the brain, because that's where our language centers are. So they're mentioning this person might also have aphasia. Don't have to know that now, just saying this is what this little key is showing. And then you'll notice that this person has 3 pluses on all these areas of his right side, means if you tapped on his reflexes, they'd be very hyperactive. This is spastic weakness, hyperactive reflexes. And then you'll notice they'll show here, if you scrape the bottom of their foot and did a Babinski reflex, that big toe would go upwards. If you scrape the bottom of their foot, that means they've got an extensor response. This is showing you that they have impaired. They might have numbness and lack of sensation over the entire right half of their body with that lesion. And then they also, if they do try to move, because of their weak, they'll also probably be incoordinated. So they're showing incoordination on that side too, is that you say lift your arm, it'll look like this. It doesn't look real coordinated. It's not fluid movement. They can't select individual movements. It's this stereotyped reflex pattern type of movement that's not coordinated in nature. So that's what that's showing. Make sense? So anyway, just as you get to those in the book, that's just so you can quickly go, oh, that's all they're meaning by that. So that's a quick way to look at when they show a lesion. They might have one in the cerebellum, and you'll see they'll show those 4 diagrams of how a cerebellar lesion affects sensation, motor system, coordination, reflexes. Okay? So that is all I want to show there. Oops. Come on. Let's see what happens.